So welcome back. I hope you've had some time to look at these questions and come up with some answers. So, do cortisone injections destroy cartilage? Well, this has actually not been proven in vivo clinical studies. There is some evidence that there may be some delay in healing of acute injury in rabbit tendons. Can they cause rupture of the Achilles? Well, this is unproven in vivo clinical studies also. There is no direct evidence that this is the case. Often people who have ruptured Achilles have undergone several months or years of degenerative change and have had steroid injections, which do reduce inflammation and reduce pain and enable them to continue to use a degenerating tendon. So do steroid injections work? They do work, but they also need to be associated with well-targeted rehab. Is it just a short-term effect? It may be, but it allows a therapeutic window for decent, well-targeted rehab. Are they painful? Not if done properly. You can use anesthetic injection for the skin, and a slow injection using anesthetic often reduces the pain. Are they a short-term fix? Again, not with good rehab, addressing underlying biomechanical imbalances. So looking at the underlying cause of the inflammation and not just trying to block the inflammation itself. And do they need repeating? But obviously not if associated with good rehab and dealing with the underlying causes. And are they the last resort? Well, they can be first-line resort in frozen shoulder and shoulder impingement, and knee OA, disc protrusions in the lumbar spine, trigger finger, for example, and first CMC joint OA. Often they have the best effect to allow some decent rehab to follow. So do they cause all of the side effects of steroids? And the answer is no, not in normal doses used in injections. Can they cause a flare or flushing, menstrual irregularity, or even local skin atrophy and fat necrosis? And the answer is yes, so the patient has to be warned about the possibility of this. Okay, so now we're going to move on to a new topic, regenerative medicine. Under this title comes Dextrose Prolotherapy, phenol with Dextrose Prolotherapy, platelet-rich plasma, mesenchymal stem cell therapy, and gold-induced cytokine therapy, all reasonably recent developments. So lumbar instability is a common reason to use Dextrose Prolotherapy. This instability may be discogenic or caused by a spondylolisthesis or pars defects, often seen in young adults in sports such as cricket or tennis and ballet. Prolotherapy can be used in arthritis of the knee and hip, in tendinopathies or enthesopathies, medial collateral ligament partial tears, in coccydynia, and it's even sometimes injected into discs, in internal disc disruption, disc degeneration. And it hasn't been known to be used in acute muscle tears and acute ligament injuries. So what does it do? It's an osmotic irritant. It's a hypertonic solution of dextrose, commonly used in 12.5 or 15%, sometimes 25%. In the lumbar spine, we inject it in solution with 1% phenol, which is more of a chemical irritant. And this stimulates migration of fibroblasts and deposition of fibrin, and the production of tropocollagen, which matures to form normal collagen fibers. If dextrose is injected in a 5% solution, in water or saline, it also acts on the sodium, potassium, calcium channels and acts as a neuromodulator, so thus dampening down sensory nerves, otherwise known as perineural injection therapy or neural prolotherapy. Part of the action of this irritation is to stimulate growth factor production from platelets, such as connective tissue growth factor, transforming growth factor beta, and so on. And the result is fibroblastic hyperplasia, and you can see a normal collagen fiber section on the left, and then on the right, the little black dots are the nuclei of fibroblasts, which have migrated in to start producing more collagen tissue. And it's been shown in biopsies that this does actually thicken the ligaments and collagen fibers, particularly at the tenoosseous junction. So we use dextrose prolotherapy in a number of conditions, particularly lumbar segmental instability and sacroiliac joint dysfunction, pelvic girdle pain and symphysis pubis dysfunction. And I did a lecture on this, the BASM, which can be found on that link on YouTube. So other uses for it include neurogenic hamstring pain, which is quite a common thing that I see. Patients referred with hamstring tears, maybe playing football, but no obvious tear on MRI or ultrasound. These may respond to epidural injection, or recurrent ones may respond to prolotherapy. We often use dextrose prolotherapy in ankle instability and recurrent ankle ligament tears, in groin pains, and also symphysis pubis dysfunction, osteitis pubis or pubic overload, tears of the MCL, as I've mentioned, the Achilles tendon, knee OA. There's plenty of evidence now that it works in knee osteoarthritis against placebo or against normal physical therapy and exercise management. Tennis elbow, it can be used in first CMC joint, AC joint, sternoclavicular, any enthesitis, and also in the coccyx when steroid injections have been ineffective. There's some controversy over it. It has been available for 80 years. It's got a good safety record. There is some conflicting evidence, as there is in almost any treatment for low back pain, with poor studies or poor methodology in the trials, but there are 4 randomized controlled trials. 2 showed a positive effect. 1 showed it was effective, but the same as the controls, and 1 showed it did not have an effect. Many insurance companies don't actually reimburse for it. As I've mentioned, we often use 3 injections at 1 to 4 week intervals, and after 4 to 6 weeks from the end of the course, we can assess the full effect. It's really important to continue with lumbar stabilization via a physical therapy program to assist in support of the lumbar spine. And on average, when people ask how long it lasts, I say around a year, but there's a huge variation between a few months and several years. The most important thing, it is safe. It is cheap. It's relatively easy, depending on which part of the body you're trying to inject. And it appears to be effective in a number of clinical trials and studies. And is often now used quite early in professional sport in ankle ligament injuries. And although we often find ourselves using prolotherapy in the older players, it's not just older footballers who benefit, but any sportsman and often the armchair athletes. And as I said, not just in the sporting population. Platelet-rich plasma, or PRP, works by promoting tissue regeneration, a bit like dextrose prolotherapy. but it's mediated by the platelets, which are injected from your own blood, and platelets produce growth factors and cytokines, stimulating platelet-derived growth factor, transforming growth factor beta, and cytokines, all producing an inflammatory cascade, remodeling the extracellular matrix, forming fibrin and new collagen. It's used in tennis elbow, knee osteoarthritis, of which there were some good studies. A recent good study on gluteal enthesitis showed that it worked better than steroid. It tends to last much longer as well and doesn't need to be repeated. There's not great support in studies for Achilles, patellar tendon, and rotator cuff, but it's worth considering. It seems to work in plantar fasciitis and in acute or chronic ligament tears. Sometimes it's used in muscle tears, but again, we don't use it on its own. We associate it with some good rehab. So it is possible to aspirate the platelet-rich part of the plasma by hand, and it can be done using several different types of equipment. There are variable studies for demonstrating or describing different procedures and protocols. I won't go into the protocols. Some have single spins, some have double spins. Some will use a tube with citrate anticoagulant in it. Some will need refrigeration to produce varying multiples of platelet yield. This is a double syringe technique to aspirate the plasma from near the buffy coat. A study in 2000, or a paper in 2019, described a high multiple of platelet concentration being obtained by using a soft spin followed by a hard spin. And however, this is only one type of protocol. You'll see, as this paper described, this extract from a paper describes several different protocols from the first centrifugation at a very high speed with no second centrifugation, so a single spin. It's a single spin being used there, and resulting in varying multiples of platelet yield. So there's a lot of research still to go on platelet-rich plasma. Personally, I use a single spin, which is likely to result in 2 times the platelet yield, and I use a manual aspiration technique. So what we don't know about a PRP is what dosage we should use, the volume, frequency, interval, number of injections, etc. How you extract the PRP, whether you use citrate, what speeds of spin you use, single or double. Should you activate the platelets using coagulants, or you just use the soft tissue that occurs within the injection itself? Should it be leukocyte rich or poor? Should it be refrigerated? So anyway, there's no evidence for the clinical effectiveness or higher effectiveness with higher concentration of platelets. So high volume injections can be used in the Achilles or the patella. Here on the left is an axial section of the Achilles tendon with the needle just deep to the Achilles. And it's often a 2-person technique, as you can see here, using saline, lidocaine, and steroid. with a high volume of injection, hopefully stripping away the near vessels from the anterior portion of the Achilles, thus reducing pain. Shoulder hydrodilation, often used in adhesive capsulitis, traumatic capsulitis, or refractory frozen shoulder after a simple steroid injection has not worked. This is an arthrogram during a hydrodilation procedure where the axillary recess has filled with contrast, and normally this means that the shoulder is full. Sometimes you'll see the bicipital groove being full of contrast. Sometimes the procedure becomes particularly painful and it's curtailed. Either way, this demonstrates that the capsule is full and the distension has had the desired effect. We often use Marcaine, triamcinolone, and Omnipaque. Here's another contrast picture of the same thing. So once that subscapular bursa has ruptured, or the contrast has gone down the long head of the bicep sheath, then that's when the injection is terminated. Normally that's 20 or sometimes 30 mils of fluid. You continue with rehab, and often there's quite a dramatic improvement in shoulder movement. So regarding WADA and drug testing, corticosteroid injections are not banned, but if they're used intramuscular or intravenous, then you need a TUE. The route and dose must be declared by the athlete, since routine testing is done also including corticosteroid testing. It is the player's responsibility to declare what they have been treated with. And that's called a self-declaration. So it's important as a practitioner that you provide all the information about the injection to the athlete. Dextrose, Prolotherapy, and PRP are not actually tested for. They're not banned. They're not detectable, but it's always sensible to notify the athlete what you've injected and the dose. Local anesthetics are not banned, but it's important again to notify the athlete. Dextrose Prolotherapy is not banned and not tested for, but just notify the athlete. So there's a few pages of references here. I suggest you look at some of these. There's some great studies that give you a few hints on the use of regenerative medicine, Dextrose Prolotherapy, PRP, and some more controversial views from opposite opinions. And as usual, more research is needed. So many thanks for listening. Goodbye.